Welcome. We are back with another live training with Candice today, who hopefully will join us shortly and smoothly. What is going on? The setup is not cooperating, but that's all right. Great to see some of you joining us live. Thank you. All right, let's see if we can just get Candice. Doesn't cooperate whenever Candice is online, which is just lovely. So let's see how we go.
Yay! Hello!
I was like ready to kill some time.
We got on first go.
We got to first go. It's a good day. Good to see you. Welcome back, Candice, to our live training. So today's topic is all about managing blood glucose levels with gestational diabetes. So for those who don't know, Candice is one of the dietitians here at the Dietologist, and she also has many, many years experience as a diabetes dietitian, and she's just completed some of the studies required to be a diabetes educator as well. So Candice is our go-to when it comes to insulin resistance, PCOS, gestational diabetes, and diabetes management in relation to fertility and pregnancy. So we have the expert on for this topic today. So we're thrilled to have you, Candice. Before we go into it, I think for potentially some of our audience who are preconception or maybe have been told that they're at a higher risk of gestational diabetes, can we perhaps just go through briefly, like, what is gestational diabetes and how do you know that you may have gestational diabetes?
Yeah, certainly. So, gestational diabetes is a type of diabetes that is first detected in pregnancy. And the good news is it's usually one that goes away after you've given birth for most people. But it is characterized by high blood glucose levels while you are pregnant. So they're the things that the doctors are testing for. And yeah, I think it's underlying insulin resistance that sits underneath that as well.
Yeah. And for a lot of people, I always talk about pregnancy being as a little bit of a stress test. A midwife that I worked with on a research study explained it to me like that. It's always stuck with me. So, whatever is potentially going to be in your future in terms of chronic disease risk, for example, type 2 diabetes in the context of gestational diabetes, pregnancy is the stress test for that. And it will show you where your body may struggle in the future in terms of future health. We see the same with preeclampsia and future risk of heart disease and blood pressure issues. And it's very, very, very similar with GD. So what is the risk? Say somebody does get diagnosed with gestational diabetes at around the 28-week mark, where they go and do that 2-hour delightful drink test and sit in the pathology center for a couple of hours with lots of blood pokes. Say that happens, they find out, they know they need to do something, and we'll go to next steps in a second. But what is the chance that that person who had GD in pregnancy will later develop type 2 diabetes after pregnancy?
Yeah, so the statistics say, I think it's around 50% or 60%, somewhere between 50 to 60% of women will go on to develop just type 2 diabetes, and that is within 10 to 20 years of their pregnancy. So it is sort of looking longer term, but it's a pretty big percentage, really. And, it's something that you've been given a bit of a pre-warning about, which I guess a lot of people don't get. And there's not a lot of symptoms when it comes to diabetes. So it is something that when we're talking about diabetes prevention, you don't feel unwell, there's nothing wrong with you, not a lot will come up in your blood work that says there's something wrong. But then once it tips over the edge into diabetes, then it's diabetes for forever for most people. So it's a 50 to 60% increased risk of type 2 diabetes in that later stage of life. So when we're thinking about hitting more that middle age period, that's when we're at bigger risk.
What are some of the risk factors for people to develop gestational diabetes? Is some of those things lifestyle, or some of those things, their family history or genetics? Like, what are some of those factors that people should be aware of in terms of GD risk?
Yeah, there's definitely a combination of things that we have absolutely no control over, and then what we like to call those modifiable risk factors. So the things we have no control over are things like our ethnicity. So some people from different backgrounds will have a higher risk of GD. There's your age. So the older you are, the higher the risk of developing GD actually is. Some of the things that we do have some control over, as we know that your weight status prior to pregnancy does impact your risk of GD as well. So we can look at things like weight management prior to pregnancy if we need to for people. And what are some of the other ones? I've drawn a blank now. Oh, if you've had gestational diabetes before, then obviously that one puts you at higher risk of developing it again. I think it's like 70%, something like that, will have GD in the subsequent pregnancies. And if you've got any family history of diabetes as well, it's another one obviously we can't do anything about, that one. But if you do have that family history, that's a risk. We know that anyone that's got any disorder related to insulin resistance, so potentially things like PCOS, put you at higher risk of developing GD as well. Have I missed anything?
I don't think so. I think the only other one that I was going to ask you about was when the multiple pregnancies increase. So if you have twins, because we were just talking about that this morning, weren't we, in our team chat about preeclampsia and twins. So it just came to mind. I was like, I don't know about twins and GD. Is there a higher risk in multiples?
Yeah, I think it is slightly higher, but it's not a huge percentage increase, but there is a slightly higher risk, definitely. And I guess we can consider that if you're carrying twins, there's a lot more stress on the body, and it is sort of the stress of pregnancy and those pregnancy hormones. With twins, you've probably got that increase in pregnancy hormone as well, and then that does
potentially two placentas pumping out.
So it's not like a double risk, but it's an increased risk.
Okay. And so say somebody finds out, you know, oh, you have gestational diabetes, and Candice and I can both attest to this. There's definitely this sense of like, why me? How did I get this? Like, what the heck? Like this sense of, you know, failure, or I did something wrong, or trying to work out why. And I think that is an important like stage to go through. But we also, because we often only find out really at the cusp of that third trimester. We have 12 weeks essentially until you have a baby to learn all about it, teach you how to manage it, teach you how to start poking your finger to take your blood glucose levels. Like we have a lot of actions that we need to take in a really short amount of time to optimally manage your blood sugar levels, because it's the blood sugar levels being too high, particularly, that can have a negative consequence on pregnancy health for both mum and bub. So what would be like, somebody finds out, what would be the next things that they should do, the next steps that they should take in their state of overwhelm and perhaps a bit of fear about what's next?
I think we did skip over the actual diagnosis of gestational diabetes there. So gestational diabetes is usually screened sort of at that 26 to 28 week mark for most people. Anyone that has a number of risk factors will be screened a little bit earlier. So prior to 20 weeks, you might have be tested earlier, and then if that's negative, you'll be tested again at that 26 to 28 week mark. And you do have a 2-hour glucose tolerance test. So you'll go into the pathology, they'll do a check of your fasting glucose levels. So you will fast overnight prior to doing the test. You drink a nice little solution that contains 75 grams of glucose. So sweeter than even any kind of soft drink you've probably ever tasted before. And then you have your blood tested again at 1 hour, and then again at 2 hours to see how your glucose levels respond to that big load of glucose. Now, if any one of those three numbers comes back above the target level, then that will be diagnosed as gestational diabetes. So it's greater than 5.1 at that fasting point. It's greater than 10 at that 1 hour point, and greater than 8.5 at that 2 hour point. So I guess women will get diagnosed, and the first step is usually to get some education around gestational diabetes. So you will normally get the call from like your midwife or your doctor or someone that lets you know, and you don't get a whole lot of other information there. And the temptation is obviously to go down the Google rabbit hole, your Facebook, support groups and all of that, and you can get some great information from those sources, but you can also get some really bad information too. So I think
scary information.
Yeah, definitely. And so it's really important as a first step that you do get some education. Now, standard practice should be that you're referred to a dietitian and probably a diabetes educator as well. And a lot of, say, hospitals will have their own gestational diabetes clinics, so that anyone that is diagnosed with gestational diabetes should be going through their hospital clinic. And they'll usually attend a group-based program to start off with in most cases, and that's where you'll learn how to monitor your glucose levels, and you'll start to learn about some of the basics around your dietary management. So how do we keep our glucose levels under control from a diet point of view? So certainly getting that first port of good quality education is really important, and then that helps you filter through some of the Google and support group stuff that's out there as well.
Yeah, absolutely.
Yeah.
And then in terms of what role dietitians play in terms of GD management, before we just jump to that, how can gestational diabetes, why is it so important to manage it? What if we just found out and we just don't care, just going to let it be? Why is it important to manage from the health perspective of both the mum and the baby? Because I think that's a really important thing. Some people are like, oh, well, this is just one test on one day. I'd never have 75 grams of glucose in one go. So does this even really matter? Like, how's this going to reflect in terms of my normal diet? Like, do I even need to pay attention to this? And so I think without having an educated but not a fear-mongering discussion about what are the impacts if we don't manage gestational diabetes?
Yeah. So the biggest one, which is the main thing that we're looking at when we're managing gestational diabetes, is preventing your baby from putting on too much weight. So this is called macrosomia, or it might be termed a large for gestational age baby on your scans or at birth. So what happens is the glucose that is in your blood, if your glucose levels are too high, the glucose crosses the placenta, and that is going to baby. Now, baby needs glucose to grow and develop. So that's super important, is that we want that process to happen. But the issue is when you've got too much glucose in your bloodstream, then too much glucose is going across to baby, and that can cause baby to put on extra weight. And the reason for that is as glucose levels go up for babies start to produce their own insulin response to that, and insulin is a growth hormone, and so it causes baby to grow bigger than they should. So that's sort of the number one thing that we're concerned about. If that does happen, there's probably a secondary concern I usually have for people after birth, and that is if baby's used to having high insulin levels, when they come out of this glucose-rich environment when they're born, babies will then get low blood glucose levels. So this can often require special nursery treatment for baby to stabilize their glucose levels after birth. So it's something, that's very kind of standard practice, and they've got really good systems to keep baby safe in that instance. But obviously mums want to be with their baby in that early stage of birth. And so if we can prevent that from happening, then we have a much smoother, transition to having baby and mum and baby connection together. And I think that's really important as well. When we're talking about mum, obviously the risks of having a large baby relate to the birthing process. So if we have a large baby, there's definitely an increased risk of birth injuries, so tears and those types of things. For baby, there can also be a risk of the shoulder, I can never say it, the dystocia, where It's one of those words I can never pronounce.
Yeah.
And so that's where baby's shoulders get stuck as they're coming out of the birth canal and can cause injury to their shoulders too. And so there's the risk of tears and all those types of nasty things. And you ask any woman about birthing a larger baby and they would like to avoid that if they potentially can. And then there is the increased risk of needing to have a C-section because of those factors as well. You will have a higher risk of preeclampsia, which is high blood pressure in pregnancy too, with unmanaged gestational diabetes. So what I think is really important when someone's diagnosed with gestational diabetes, and we talk about all these risks are related to unmanaged gestational diabetes. So when the levels are too high, if you're diagnosed with gestational diabetes and you're managing your glucose levels really well, then all those things are much lower risk. And that's where we sort of come in with helping to manage that.
Yeah. Awesome. So the aim of the game is ultimately to have our blood glucose levels, so the amount of free glucose, or sometimes people call it sugar, but glucose doesn't come just from sugar, so I try to avoid using that terminology, but free glucose in the bloodstream. We don't want that to be too high because then that will get to baby. Baby will kind of get bigger than perhaps what they should, and that can affect birth outcomes, affect them post. So the aim of the game is to kind of keep the blood glucose levels within a certain range before and after meals. So this is where dietitians come in, because Candice, what is the most relevant factor when it comes to diet and blood glucose levels?
Yeah, so it's definitely our carbohydrate foods. I want to say that it's not only carbohydrate foods, so that's also something that's really important. But when we're talking about management of your blood glucose levels, carbohydrates are the first thing that we are going to look at. Because when we eat carbohydrates, carbohydrate foods turn into glucose, and that causes our glucose levels to increase. So if we are managing the amount and the quality or the type of carbohydrate that we're eating, this is ultimately what's going to help you, probably the biggest thing that's going to help you with managing those glucose levels and keeping them in target.
And the most important thing is that you don't go and have a low carb diet the moment you find out you have gestational diabetes, because we see this all the time. And we know that too low carbohydrates is not good for baby either. So it's actually about matching the amount of carbohydrates to your lifestyle, how active you are, what your job looks like. You know, if you're a teacher running around the playground every 5 seconds and are constantly standing, you're going to have a very different need for carbohydrate as fuel than somebody like me who sits at my desk for like 12 hours a day. You know, it's a very different lifestyle, and therefore carbohydrates need to match. And even within, you know, the different types of carbohydrates and amounts of carbohydrates, each individual is going to react very differently. And we see that so often. You know, somebody will be like, what the heck? I had, you know, XYZ grams of carbohydrate in rice and the exact same amount in pasta, and I got completely different blood glucose readings. Like, what's the go? Like, I thought they were both low GI or whatever. And that's that like bio individuality of it, which is why one-on-one support is so important for GD as well. What are some of your top tips in terms of, for those out there who may have just been diagnosed with GD or worried that they might be, what are some of just your top line tips, general tips in terms of managing blood glucose levels from your years of experience in this area?
Yeah, so certainly the first thing I would look at is probably the quality of the carbohydrate that you're eating. So we want to be trying to choose more of those high fiber, whole grain based carbohydrates as opposed to those processed, refined carbohydrates. And particularly like those foods that we call those ultra processed foods that are high in sugars and fats and all the good stuff. So it's looking at that quality, I think is really important. The second thing you probably want to do, and it's pretty much as important as the first, is manage the portion of carbohydrate that you're having. So it is the amount of carbohydrate at each meal and snack across the day. And we have sort of very specific generic guidelines that sit around that, but then the individualization of that based off your activity levels and all those other bits and pieces are what is really important. So if we're eating good quality carbohydrates and the right amount of carbohydrate, then this is really kind of going to set the foundation for everything else that we need to do. Probably the last thing I think is really important is really trying to make sure we're meeting as many of the requirements as we can for a healthy pregnancy as well. So we're talking about diet quality overall here. And so we're talking about making sure we're eating enough veggies, enough fruit, we're getting our dairy in, we're eating enough protein, we're eating whole grains. And that is one of the most important things just to support a healthy pregnancy overall. It's just getting that diet.
That is so often forgotten when it comes to GD, because people just laser down and focus so much on, I just got to get the number of carbs and the right type of carbs, and then they forget that food has a synergistic effect. The way that carbs will work in your body, for example, alone, if I just ate a plain slice of toast, just say for example, versus if I eat that toast with eggs and tomato and cheese and avocado and spinach, would be extremely different, even though the carbohydrate value of that meal is exactly the same as the plain piece of toast. So nothing works alone, and the system kind of approach is really important. My other favorite tip, which has got really nothing to do with nutrition at all, is physical activity and sleep. So like, actually, my favorite tip is to go for a little 10-minute walk after your meals. If you can, it helps just with, getting yourself a little bit of movement in each day. You do 10 minutes times 3 meals, you got your 30 minutes of activity for the day. So it's always a good thing, especially when you're pregnant. But it can really help with lowering blood glucose levels if you're struggling with those post-meal levels. The most important thing that people often forget is that they think that their carbohydrates need to come down if their blood sugar levels are not responding well. But if you've got the right type and amount of carbohydrates, we don't want to go too low. Then the question then becomes, what medical interventions can we use to support you? Because we don't want to just like keep going lower and lower and lower. It's not that game, because there will be health consequences if you go too low. And then the other one is sleep. And sleep is very challenging if you are pregnant with a, second or third baby and you have a young child. But interruptions to sleep can have such a significant impact on your glucose and insulin responses in the following day, your appetite for higher energy, higher carbohydrate, higher sugar, higher fat foods. So prioritizing your sleep, if you are pregnant with your first, you probably have a little bit more luxury to prioritize this. Or if you have an older child who sleeps well, then please prioritize this, because it can make such an impact. And sometimes I prescribe extra sleep to my clients as a blood glucose strategy, management strategy, because it works, and they're often so surprised that it works. But just like one more hour of sleep, and this will may be the difference. So it can make a really, really big difference outside of your diet as well. Anything else to add, Candice, before we wrap up?
Well, I guess probably just one other thing, just from a safety point of view around that lower carbohydrate stuff. I guess it's really important to know that the risk of going too low in carbohydrate is that you might start to develop something called ketones. So when we're on a low carb diet, everyone knows the keto diet. The purpose of a low carbohydrate keto diet is for your body to produce its own ketones. Now, the issue is that those ketones can harm the development of your baby. And that's why we don't want to go too low. And the problem with that in pregnancy is that we don't know at what level a pregnant woman starts to develop ketones. So we know that out of pregnancy, when we're at sort of that 20 grams, 50 gram of carbohydrate per day, that's likely to start producing some ketones. It's likely to be much higher in pregnancy, but we don't know that exact number. And
you can't really test that.
No, we can't ethically.
It would be like,
no
way. Yeah.
we just don't know what the minimum safe amount of carbohydrate is, but we've got rough ideas on what it is anecdotally and from clinical experience and those types of things. So it's really important, I think, just to make sure you're eating enough carbohydrate. And definitely, if your levels are still high and you're doing all the right things, it's not your fault. It is the hormones that are produced by your placenta that are causing this issue to be exacerbated. And that's we need some medical intervention to assist with that. That's okay. It's not a failure on your part whatsoever.
Yeah. Absolutely. See so much emotion, I think, compounded by, pregnancy itself, but, that feeling of like you feel like you're failing your baby before they're even born. And there's a real intense emotional attachment to that. And I think working with somebody where they can reassure you that you've done all the right things, you've done everything that you can, it's not your fault, and everything's going to be okay. And this is where we call on, our endocrinology colleagues to review the situation and see what goes on. And there is a bit of an uphill battle from 28 weeks till about, 36, 37 weeks in terms of how much insulin your body needs. It's so much. And so this can happen. Some people will be fine with diet and lifestyle management alone, and others won't and will require some more support from things like insulin. So, and that is okay. And that is okay. But I think the other component is making sure that postpartum follow-up is also done post baby. I think too often we just go, oh, placenta's out, GD is done, don't worry about it. But retesting, making sure you didn't have underlying diabetes, and also implementing a long-term management strategy for your diet and lifestyle to minimize that risk of type 2 diabetes in 10, 20 years time, because ultimately you just had a baby. You want to be there for all their milestones in the long term, and you don't want type 2 diabetes to be, potentially cutting off, precious years of your life because of GD. So putting in a management strategy is also really, really important and often forgotten. So I think we might leave it there because I know you've got to dash into more client consults. But thank you, Candice, for joining us and sharing your incredible wisdoms. And I'm sure we will have a few questions from this. So if you do, please leave them in the comments below and we'll get back to you. And if you'd like some nutrition support for GD, then Candice is available for one-on-one consults. Just let us know and we'll send you the link. All right, everybody, have an awesome rest of your day. Thanks, Candice. Bye, everyone.